Welcome. Thank you for standing by. At this time, all participants are in a listen-only mode. At presentation, we will conduct the question-and-answer session. To ask a question, please press star followed by the number 1. Please note that this call is being recorded. If objections, you may disconnect at this point. I'll turn the meeting over to your host, Ms. Renee Sednew. You may begin.
Thank you everybody for joining our Midwest Quarterly Stroke webinar. Good morning. Next slide. So we did the login instructions, and these are the same that everybody received in their email yesterday afternoon and this morning. Please contact Kristen Matthew at email or phone number if you have any issues, as Lynn and I will not be able to respond in a timely manner. Next slide. Thank you for joining our webinar series. Again, these webinars are open to anyone interested in improving stroke care, and the purpose is to engage in educational opportunities, to network, and most importantly, to share best practices to improve stroke patient care. They are 1 hour, and our next one is scheduled for February 21st, and we will be walking through and reviewing award data for the 2018 Get With the Guidelines Stroke Award Cycle. The registration link is provided, and we also included a save the date as one of your attachments. Next slide. We have a networking group, and this was a question on your registration if you would like to join. And the purpose is simply to connect directly with other hospitals to share best practices. If you would like to join, please contact Lynn or myself. Currently, we have 368 participants. Congratulations to Midwest Get With the Guidelines Stroke Hospitals. 227 hospitals in our Midwest affiliate were recognized for a Get With the Guidelines Stroke Award, and of those, 166 received the more challenging target stroke recognition, so great work. Next slide. And hospitals are recognized on our U.S. News and World Report Hospital Around the Corner ad. This is online, available to the public, and includes all hospitals across the country, along with any Get With the Guidelines award. Next slide. I have a printed ad as well that recognizes all hospitals in the country for their Get With the Guidelines award status. And I'm going to hand it over to you, Lynn.
Thank you. Good evening, everyone. Thanks again for joining us. Just a couple of quick announcements before we go into our key presentation for today. As most of you probably know, an estimated 15% of strokes are results of untreated atrial fibrillation, so we wanted to make sure to let all of you know about a really exciting opportunity we have for those hospitals that might be interested in trialing our Get With the Guidelines AFib program. There's a free trial opportunity available through the end of this year. So if you're interested in this great quality improvement tool, please feel free to reach out to your local QSI director. Or if you're not aware of who that person is, Renee and I would be happy to help you connect with them. Stroke resources. I won't go through each of these, but they are available by links through the slide that you received this morning from Kristen. You can just go ahead and go to the link within the PDF of these slides. Some great information and additional resources for you to use in your hospitals and your community. The Stroke Rehab Toolkit is a wonderful resource that we have for you. If you were able to listen to the guideline presentation within the last couple of weeks, great. If not, you can link to the Stroke Rehab Toolkit as well as a highlight of the guidelines on this link here. I want everyone aware of our fall stroke campaign. October 29th is World Stroke Day. I have wonderful resources available for that as well. In addition to the for World Stroke Day with iPlan, you have your stroke survivors and other volunteers World Stroke Day campaign on what they plan to do instead of having a stroke. We also have a wonderful new video, and the YouTube link is available on these slides as well. Our upcoming events, again, October 29th, World Stroke Day. We have World Stroke Day, several other events coming up within our affiliate and nationally. That's where these resources, as well as the registration links to these events, can be found in your slides for today. Now, it is my pleasure to introduce our guest speaker for today, Laura.
Thank you for the introduction. Good morning, everyone. I am excited to be speaking with you all this morning. I have a lot of content to go over, so I'm going to go ahead and get started. I want to make sure that we get through all of the slides. Oh, there. Okay. So I always like to start off my presentations just going over some groundwork and re-explaining the stroke certification offerings that we have in place. As many of you know, the Heart Association, we co-brand our stroke certification offerings with the Joint Commission. There are other national accreditors that offer stroke certification, but for today, I'm going to be focusing on our co-branded programs. As you can see here, you'll see all of our current and coming stroke certification offerings. What probably is standing out to most of you is that there is now a fourth certification that you can see here in this diagram, and I'm going to be covering that in some later slides. Current stroke certifications, we have 3 in place, and the first is Primary Stroke Center, which was launched in 2003. Certification was based on the Brain Attack Coalition's recommendations that they published back in 2000. Those recommendations were updated in 2011. Comprehensive Stroke was our second certification that we launched in 2012, and those recommendations were published back in 2005. And the most recent certification that we launched was Acute Stroke Ready. The Brain Attack published recommendations in 2013. And so we'll notice here that all 3 of these certifications have in common is they are all based on the Brain Attack Coalition's recommendations. So if you are part of a stroke center or you are thinking about pursuing stroke certification, I encourage you to go and read the Brain Attack Coalition recommendations because the foundation of the certification came from these publications. Primary stroke certification. This certification, as I mentioned earlier, it's co-branded with the Joint Commission and the Heart Association, and centers have the ability to care for patients that are experiencing ischemic stroke. So that means they have the ability to rapidly assess, image, and administer intravenous thrombolytic therapy. We know that 1/3 of our primary stroke centers also provide mechanical thrombectomy procedures. Centers often transfer patients that are needing a higher level of care to comprehensive stroke centers. Typically, these are for neurosurgical emergencies and patients with hemorrhagic strokes. Primary stroke centers currently are submitting the 8 STK standardized performance measures. The stroke center certification builds on the primary stroke center certification. In addition to all of the PSC requirements, advanced imaging like CTA and MRA is required. There's 24/7 availability of neurosurgical services, including the ability to coil and clip aneurysms, and there are volume requirements around those procedures. Comprehensive stroke centers also have the ability to concurrently meet multiple stroke patients' needs at one time. They also participate in IRB research, and there is also increased education requirements for the staff. PSCs currently submit 16 stroke performance measures, the 8 STK measures that the PSC submit, and there's also an additional 8 PSTK measures. Acute Ready hospital certification. So what we know is that 50% of our population live 60 minutes away from a primary stroke center. These hospitals are probably smaller and may not have all of the resources to pursue primary stroke certification. However, these hospitals still have the ability to perform a rapid assessment, rapid imaging and lab results, and the ability to administer intravenous thrombolytic therapy. Most commonly, these centers will transfer their patients to a high level of care, either primary stroke center or a comprehensive stroke center. There are going to be standardized performance measures released in January of 2018. You can see that there are inpatient measures and outpatient measures. So if you would like more information on these measures, there is information on the Joint Commission website, and I do have a link under the resources slide at the end of my presentation. Revisions to the current stroke programs, all three of the current programs that we have in place. Maintenance to these programs typically occur every 2 years. The Joint Commission does have a technical advisory panel that's made up of stroke experts. So it's this panel and also feedback that they receive from the field that contributes to these revisions that we see. There are pre-publication standards on the Joint Commission website that outline the revisions that will be in place for 2018. Most of these revisions consist of maybe moving some requirements around so that they apply across all programs under the same standard. They have deleted some redundant requirements and then also added some notes to help clarify. Here's of the revisions that you'll see under those pre-publication standards. So for PSC and acute stroke ready, you'll note that there is clarification regarding telemedicine. That telemedicine is not needed if the ED or if the ED practitioners are privileged in the diagnosis and treatment of acute stroke. So this is really important if you are pursuing certification and you're contemplating whether or not you need telemedicine service. Only get with your HR department and pull your ED practitioner's privileges to see what is included regarding the diagnosis and treatment of acute stroke. There's also been some language changed at the PSC level regarding the completion and interpretation of non-contrast head CTs. And then for CSCs, the removal of the depression screen prior to discharge was revised, and screening requirements were also revised with regards to who needs to be on site versus who needs to be on call. Thrombectomy capable stroke center certification, you all have probably heard a little bit about TSC. And so the first thing that you're probably thinking is, why was TSC needed? So what we know is that not all primary stroke centers are alike, and we also know that a third of our primary stroke centers are performing mechanical thrombectomies. There have been recent studies showing that there's efficacy in this procedure for large vessel occlusive ischemic strokes, and we all know that there's an importance of having a dispersed network of hospitals that are certified so patients can receive the urgent care that they need. However, with the addition of TSC, CSC resources are available to care for more complex stroke patients. So in other words, these centers will have transfer protocols in place with level of care centers for subarachnoid and intracranial hemorrhages. To meeting all of the requirements for primary stroke certification, TSCs will have a minimum mechanical thrombectomy volume requirement. They also will be required to have the ability to perform these procedures 24/7. There to be a dedicated intensive care unit or dedicated intensive care unit beds to care for the acute ischemic stroke population. There to be availability of staff and practitioners closely aligned with the CSC expectations. And there also will be a process in place to collect and review data regarding any adverse patient outcomes following the mechanical thrombectomy procedure. These will be expected to submit data for their performance measures, and you'll see that the 8 STA measures are going to be required. But then there's also going to be an additional 5 CSPK measures that TSCs will need to start collecting. Certification is going to launch in January of 2018. If you are interested in reviewing the pre-publication standards, those were published last month, and you can find those on the Joint Commission website. And if you are interested in converting from PSC to TSC, you actually go to the Joint Commission website and submit an application form, express interest, and they will work with you to make that transition easier. So if your survey date is coming up between now and March 31st of next year, they are willing to extend that window so that you don't have to undergo 2 site visits. Officially opens up, or the application process officially opens up in January of this year. So the great reasons to pursue stroke certification. So one of the reasons is that certification provides a framework which is based on those Brain Attack Coalition recommendations. It provides evidence-based care to help improve the patient outcomes. It assists your hospitals in establishing a consistent approach to care, which will then result in a reduction of variation, a designation for excellence in the care of stroke patients, and it's a loyal, cohesive clinical team. So many of you may think that your team is functioning great right now, but nothing will really bring your team together even more than when you were preparing for your on-site visit. Certification demonstrates a commitment to a higher standard of clinical service. It's to differentiate you in the market. In some states, it may even fulfill a regulatory requirement. So a lot of great reasons to become certified. With that being said, I'm going to transition now into reviewing some different ways that you can prepare for your survey. So prior to joining the Heart Association, I was a stroke coordinator. I've worked at the primary stroke center, and I've also worked at a comprehensive stroke center. So like many of you, I've been deep involved in preparing for a site visit, and I've been tasked to get our hospital certified. So with that being said, I'm going to take off my AHA hat, and I'm going to put on my coordinator hat. I just want to make sure that you're all aware that from this point on, any tips and tricks that I'm providing you are strictly from one stroke coordinator to another, and these have not been endorsed by the AHA or the Joint Commission. So talked about this on previous presentations, but I always like to reiterate what are the first steps in helping you to prepare your site visit. So the first thing you need to do if you've been tasked to become certified is to really look at the different certifications and figure out which one is the right certification for your hospital. So if you're not currently certified, I would recommend you go ahead and read those Brain Attack Coalition recommendations. As you're looking through standards, it will become very clear where those standards have come from, and I think it'll help to make the certification process to make more sense. If you still would like to look at some additional resources, the Joint Commission does have a comparison grid on their website. So if you want to see all 3 of the current stroke certifications side by side, that resource is available to you now. They are working on incorporating TSC, and so that resource should be available within the coming months. So which certification you're ready to pursue, the first thing you need to do is get a copy of those standards. So contact Joint Commission, get a copy of the standards, and then start gap analysis. I've mentioned the gap analysis, I think, every time I've had a presentation, but it really is so important to identify the gaps in your program so that you know where to focus all of your efforts. Here's an example of what I used when I was getting organized for my site visit. So I took all the standards and I put them in an Excel document, and they had different columns. So I had one column that identified who was responsible for that standard. I had another column where I could include any talking points. So if there's something that I wanted to make sure I communicated during the on-site survey, I had that information in my spreadsheet. And then the rest of the spreadsheet, it's columns that are 3 different colors. The first column is green, and basically what that column means is that we've met the standard, and not only have we met it, but I have supporting documentation to show that it's been met, and have that documentation filed away in a binder. I have which binder I can find the document and the actual location, so which tab it's under. And this helps me to quickly identify all of the resources and material that I'm putting together as I'm preparing for my site visit. And it also helps me to find things quickly during the on-site visit in case the surveyor is requesting something. A lot of people inquire about having actual binders versus electronic, be some type of electronic storage of all of your documents. I think both are great options, but I always get really nervous for an on-site visit that something's going to happen to maybe my SharePoint site or my site where I've stored all of these things, and I would just hate for that to go down during an on-site visit. So I'm still a big advocate of having paper copies of everything. A yellow column, that would be the process of meeting a standard. So it's not filed away. I'm not completely done with it. I'm still working on it somehow, but we're not starting from scratch. And then the red column would be those standards that we don't have anything in place to meet that particular standard yet. So when I opened up my spreadsheet, this was always really helpful for me to see at a glance when I needed to focus. And so I would always go to the yellow and red boxes, and then that would help me to prioritize my time and make sure that I'm really tackling those areas where I've identified my gaps. So while you're putting those standards into your spreadsheet and you're doing your gap analysis, you're probably going to come across some that you don't fully understand. So there are a few things that you can do. First that I would recommend is submitting your question to the standards interpretation group at the Joint Commission. I have a link to that website under the resources at the end of my presentation. I always submitted my questions to this group in case I wasn't sure if what I had in place acted at the intent of the standard. Other resources that you have available to you is that there are national listservs that you can join, also regional listservs, and usually there's stroke coordinators that are part of these groups, and it's really just a great venue to ask questions and get support from one another. We are developing an AHA hospital network, and so I'm going to share more information on that later on in the presentation. And then reach out to their stroke coordinators. So if you're part of the system or have transfer agreements with hospitals, reach out to the stroke coordinators and see if they'd be willing to help you, see if they'd be willing to mentor you with any questions that you may have. Where should I focus? When you're looking at your gap analysis and you're looking at the yellows and the reds and you think, this is overwhelming, where should I even focus my attention first? I also looked at the things that would require additional resources, so additional funding. Am I going to need extra personnel for this particular standard? Am I going to need extra equipment? So things that you're going to have to take to your administrator and get their buy-in from leadership in order to pursue moving forward with that standard. The next area that I would focus on are clinical practice guidelines, and I'm going to talk a lot more about those here in a few slides. But you want to make sure that you have clinical practice guidelines in place and that your CPGs are reflected through your policies, your order sets, and your protocols. So in regards to acute stroke-ready hospitals, there's areas where I feel like you should really focus out of your efforts. EMS, your relationship with EMS, how you work with them, the protocols that you have in place, your emergency department, and your transfer agreements with a higher level of care. So all of these areas are focused on at all three levels of certification. But if you're not admitting patients and you don't have an inpatient unit, you can guarantee that a surveyor is going to spend a lot of time looking at your emergency department and your EMS part you have in place. Clinical practice guidelines. These are the questions that you should be asking yourself. Do you have clinical practice guidelines in place? If you have them in place, who approved them? When were they approved? And what documentation do you have to reflect this? The things that I did was whenever a new guideline was published, I would take that to my stroke committee and I would present the guideline. We would discuss it. If they wanted to move forward with incorporating that guideline into our protocols and our program, then I'm sure that was reflected in our meeting minutes. If you have clinical practice guidelines in place, you want to make sure that they're the most current version. So guidelines are always being published. We have the Heart Association is going to be publishing updated guidelines for stroke care in the next few months, and so that's something that you'll want to look out for. And Brain Attack Coalition is also going to be publishing updated recommendations. So two things to keep on your radar that will be coming out in the future. And so again, your clinical practice guidelines should be the framework for your program, and it should be reflected basically through everything. It should be reflected in your order sets, in your calls, and your policies. Next slide. If you start with your guidelines, then we have on our website where you can search all Heart Association guidelines and statements, and you can actually filter them by stroke. So if you would like to look for new guidelines or make sure that you're using the most current version, then I encourage you to visit our website, and that link is under the resources for the end of the presentation. Next. Here are examples of some guidelines that I pulled the other day. So you'll want to make sure that inclusion and exclusion criteria for IV-TPA for acute ischemic stroke is incorporated in your CPGs. There's some recommendations for telehealth in cardiovascular and stroke care, and there's also a guideline for rehabilitation and recovery. So if you admit your patients and you have an inpatient area at your hospital, I would encourage you to review the rehabilitation and recovery guideline. You may find some things that you want to incorporate into your program. Others that I found, there's a telemedicine quality and outcomes in stroke paper. So if you are using telemedicine or you're thinking about using telemedicine, this would be a great paper to reference. In 2015, the Heart Association published an update regarding early management of acute ischemic stroke care, including endovascular treatment. And with all of the recent studies that have been published regarding endovascular care, I would encourage you to definitely read this publication, especially if you offer this procedure at your hospital. I also found another one on AEM. So you have a neurosurgical service at your hospital. This is a guideline or a paper that you may want to reference as well. So when we talk about clinical practice guidelines being reflected in your order sets, what does that mean exactly? So an example that I can think of is, say you're using a guideline or you found a guideline that references blood pressure parameters, maybe for your hemorrhagic stroke population. You take this guideline to your stroke committee or whoever's involved with approving guidance and decide they want to incorporate these recommendations into your program. So first of all, make sure it's reflected somehow, documented somewhere, and you want to make sure that those pressure parameters that your committee has approved are reflected in your order set. Next. So look at your order set. See that you'll have these blood pressure parameters included. So the blood pressure is documented by your nursing staff and EMR, and it is outside of the parameter that you have you've pulled from your clinical practice guideline. So number 2 is really, really important. Does order set provide instructions or an order for what to do when something like this happens? So it's easy for us to assume that all the nursing staff, all of the practitioners know exactly what to do when something happens. But the staff have been tasked to remember so many different things. We can't make that assumption. So it's really important to make sure that a blood pressure parameter, documentation is outside of that there is an order instructing the staff on what to do next. And next thing you want to make sure is that the staff actually follow the order. And more importantly, does the documentation reflect that they actually follow the order? So if in your order set there is an order to administer a PRN medication for blood pressure over, let's say, 160. And blood pressure is, in fact, over 160. The next thing a surveyor is going to do is they're going to go to your MAR and see, okay, was that PRN medication actually given? Because that's what it outlines to do in the order set. This is a lot of detailed work, and you really have to become a detective when you're looking through your charts at this level. And for me, it was impossible to look at every single chart at this level of detail, but I definitely did spot checks. I would look at charts every now and then to make sure that order sets were being followed and that the documentation reflected what was actually being ordered. Next slide. Gears to practitioner competencies. This is an area of focus during an on-site review, so you want to make sure that your competencies are not only for new staff, but they're also ongoing. So we incorporated a competency, an annual competency, and we made sure that every year the staff were checked off to this competency. For your acute stroke-ready hospitals, if, say, the emergency department, you include the administration of IVTP in your competency, you're going to want to make sure anything like this that could be a low-frequency event is included. So when you're pulling your charts and you're getting all of your documentation ready for a surveyor and they see that you've only administered TPA maybe once or twice, they're like, this is a low-frequency event. How has the staff been kept up to date? How have they been kept educated and competent to perform this task if it's not happening frequently? So make sure that those low-frequency events are definitely included in your competencies. An example of a competency that I shown during prior presentations, this is one that we created for our CSC on-site review, and this is really just to serve as a template. This does not reflect the actual standards or requirements as of today, but we built this based on what was required of our staff in preparation for that on-site survey, and then we incorporated this annually. Feel free to take this and use this template in case you need to build a competency for your staff. So when it comes to practitioner education, you want to make sure, particularly at the acute stroke-ready hospitals, your ED providers have been educated to the clinical practice guidelines. And so there are a few different ways that you can do that, and you may need to take a variation of some of these ideas or maybe get creative and come up with your own. But one of the things that we did at my hospital is that we attend the ED practitioners in-person meetings that they had. And sometimes we had staff that would call in, they would attend virtually. And so I would make sure if I was presenting something specific to stroke, particularly the clinical practice guidelines, I made sure to get documentation of everyone's attendance, proof that they received the information. You could also create an ED stroke quiz and include some questions about your clinical practice guidelines, require that they submit their answers, and then score those quizzes and then tailor further education around areas of need where maybe they didn't perform well. You could also consider posting an announcement on a bulletin board in your emergency department and having practitioners sign it as they read through the information. Or maybe you've come up with something totally different. And so get creative and take some of these ideas or use your own and tailor them to the setup that you have in place and what will work best for your staff. What's to education, and not just practitioner, this could be staff education, nursing education. So for the acute stroke-ready hospitals that, resources can be scarce and it can be difficult to create these education opportunities. So some of the things you may want to consider is partnering with your primary stroke center or your comprehensive stroke center. If you're not part of a system, look at those hospitals that you have transfer agreements with they would be willing to help you with your education needs. So it asks the PSC or the CSC to attend, your staff could attend on-site education events. If that's not possible, ask if maybe your staff could attend virtually, or maybe the PSC or the CSC would be willing to video record their on-site education and then send you a copy that you could use with your own staff. The thing that I did is we created a mobile stroke education opportunity. So we took 1 hour of stroke education to the various nursing units in the hospital. And the way we did that was we actually worked with industry. So we worked with Stryker. Stryker had someone come to our hospital. They helped us to create content, and that person actually showed up at 7 a.m. on a few different days. They went to the various nursing units at shift change and provided an hour of stroke education. And so I definitely used that opportunity. I had copies of the presentation, I had sign-in sheets, and then I definitely used that towards my education requirements. I can only speak for Stryker because that's who we worked with, but some of the other industry companies, they may be doing similar things as well. So that might be something that you want to explore. You can look at online and virtual opportunities. So we are currently in the process of trying to offer the nursing symposium at the International Stroke Conference through Stroke on Demand, would be a virtual presentation of that symposium. So I'm hoping in the next couple of months that we'll have more information on that, and that might be a great way to virtually send your staff to ISC if they can't attend in person. And then something else I did was that I looked for 1 hour webinars that were being offered, and I would schedule those in a group, schedule a group viewing in a conference room at the hospital, and I would send it out to all the stroke units and have everyone attend at once, and I had sign-in sheets, and I definitely counted that towards my stroke education. And I do have the opportunity to send someone to a conference and then have them come back with the expectation that they need to provide some type of education to the staff on some things that they learned. Maybe present a 1 hour update on, something new that they learned at a conference and count that towards your stroke education. So a lot of creative ways that you can provide education to your staff. And if you have any questions about any of these or want to explore any of these opportunities, I'd be happy to do so. Next slide. Review. I don't think I've touched on this in the past, but this is something that is so crucially important. Make sure that your documentation is the way it should be, and also to prevent any fallout with your performance measures. So if you're overwhelmed with where to start with your concurrent review, I would encourage you, if you're a primary stroke center or if you're a CSC or considering TSC, definitely start with those STK measures. If you are an acute stroke ready hospital, now that we have those measures published that we'll begin collecting early next year, go ahead and start looking at those concurrently. You want to try to catch these in as close to real time as you can so that you're preventing fallouts. I've done this a few different ways. Initially, I created a paper tool. I would have a form for each patient, and I would check off every time a measure was met or highlight when something was missing. Then I eventually transitioned to a spreadsheet, and I would put all of our stroke patients in this spreadsheet, and then I would document as those measures were being met. I also included any feedback that I was giving to the nursing staff. I would document that in my spreadsheet so that someone questioned whether or not I tried to address a fallout before it happened. I had that documentation readily available. As you're starting your concurrent review process, you're going to want to make notes of what performance measures have and don't have discrete fields in your electronic medical record. This is so important because everything that has a discrete field, there is potential to build a summary report that pulls in all of those discrete fields into one place. So something that really cut down on my concurrent review time was that I had discrete fields made for every single performance measure, and then my EPIC team built a summary page that pulled all that information into one place. So at a glance, I could see every single performance measure without having to flip through the entire EMR. So work with your IT folks, work with your EMR to see if that's something that you could possibly do. Current review process, I have a few different ways of communicating my findings to the staff. One of the things that I did was I would send the emails to the managers letting them know, no patient in room 308, they don't have their SED on, it's not documented at least, or it looks like they didn't get their aspirin. And so I would create these daily emails and I would send it to the unit managers, and then it was up to them to get with their staff to make sure that those areas were addressed. Also tried doing daily rounds at one point where I would do my concurrent review first thing in the morning, and then I would go round with the stroke team and address any performance measures. Then I transitioned from that, and we actually created a sticky note in the EMR that was for nursing to nursing communication. So as I was doing my concurrent review, if I found anything that was missing, I would put a note in this sticky note, and I would say, you know, it looked like stroke education has been documented yet. And so the nursing staff were able to see my documentation in the EMR concurrently every day, and I would change it every day depending on what was missing or what was needed. And the great thing about the sticky note was that it wasn't part of the permanent record, so all of that information disappeared when the patient was discharged. So that's creative ways, a lot of different views that you can take when you're communicating any of your findings that you're coming across during your concurrent review. For many of you, you're probably thinking, this is all great information, but I'm just a one-man show here, and I can't do all of these things. So I was always trying to find extra resources and extra help. And so I was always asking, is there anyone on any of the units that's on light duty right now? And I would have our administration give me a list of people who had been transitioned to light duty, and they would come work with me, and I would help them with I would give them some projects or tasks to help me with the things I needed to accomplish every day. Look to your administrative support, so any administrative assistants that might be able to help you at least with some of the things like meeting minutes or, you know, pulling handouts together. Some of that administrative work, if there's anyone that you can reach out to who might be able to help you. And then one thing that I did not know, I'm actually embarrassed that I did not know this, was that we were participating in Get With the Guidelines, but I didn't know that I could have the assistance of my local QSI director to help me comb through my data and look at how I was performing and help me to get back on track with meeting any performance measures where I may have not have been doing so well. So definitely reach out to your local director and ask for their assistance, particularly when it comes to better understanding your data and improving your processes. And definitely join a listserv. I think that the listservs out there are a great resource, and you'll find that most stroke coordinators really help one another, and they're willing to share what they've already created so that you don't have to start from scratch. That being said, if any of you are one of our comprehensive stroke centers, you may be a member of our CSC online network, and we are really excited to announce that we're actually expanding this online network to include all of our stroke certified hospitals at all 3 levels and including TSC next year. So we will have more information about that online network expansion in the next couple months, and I make sure that Lynn and Renee, they both have that information, and I can distribute that to you. Right. As Lynn mentioned, the Joint Commission is having an Acute Stroke Ready Hospital webinar on November 8th. So if you would like more information about that webinar, please go to the Joint Commission website and go ahead and register. These are just some of the resources. I've got guidelines, the Joint Commission resources, as well as our national listserv, different things that you can review to help with your program and your processes. Next. And then I also have my references for all of the Brain Attack Coalition recommendations. So if you haven't read those, please go read them. It will greatly help you prepare for your on-site visit. And that's the end of my presentation.
Thank you so much for a wonderful presentation, Laura. I apologize, I didn't give you a proper introduction before your presentation. For those of you that don't know, Laura is our Accreditation Services Manager for AHA-ASA National Center. She oversees our certifications offered through the Joint Commission and the American Heart Association. She's in that role since 2015, and as you've heard, she has wonderful wealth of experience as a stroke coordinator prior to that role, leading the second comprehensive stroke center in the United States through a certification with 0 recommendations for improvement. So we always really appreciate having Laura as a speaker. Her expertise and tips from both her AHA hat and her prior stroke coordinator role. So thank you so much, Laura. We are going to go through a couple of slides with questions that we gotten submitted prior to webinar today. A question in particular about if you are interested in pursuing acute stroke ready, how does this work with Get With the Guidelines, and where can you get some of those information from? So we will just go through those quickly and then open it up for questions for Renee or myself. So looking to find some of this information, if you're participating in Get With the Guidelines stroke, you find the majority of the information that you need for performance measures in that acute stroke phase through the additional time tracker in Get With the Guidelines. The slide that you see on your screen now shows find the additional time tracker. You would click to expand this and open up all of the data fields for the time tracker. So things that are very important to that particular phase of caring for the acute stroke team, the acute stroke patient. So when your stroke team is activated, when the stroke team arrived, the time ED physician got to the patient, if neurosurgery was consulted, brain imaging, your lab tests, EKG, TPA, chest X, all those very important time components for caring for that acute stroke patient you'll find in the additional time tracker. We compiled all that data into the patient management tool. If you go to your configurable measures report, you can find the patient time tracker report there. And we click through that, this is what you will see in your patient management tool expert, really focusing at acute stroke care phase for those patients. So we want to make sure that we address that. We did get quite a few questions about where you would be able to capture that information and Get With the Guidelines. So open it up for questions. So operator, if you could please instruct the participants how they can submit a question.
Thank you. Participants over the phone, we will now begin the question and answer session. If you would like to ask a question, please press star followed by the number 1. Please ensure your phone is unmuted and clearly record your name when prompted. For your question, please press star 2. One moment, please, for the first question.
And as Renee said, there are some questions in the Q&A box. I'm not sure if you can see those. Well, if not, I can read them to you.
Okay.
I can see several questions about the thrombectomy-capable volume requirement. So we have been receiving feedback about the volume requirement, and that is something that we are discussing with the Joint Commission, other national organizations. And so right now, it doesn't appear that the volume requirement is going to be changing, but we are discussing the feedback that we're receiving, and we will make revisions if necessary and this deemed appropriate. So there will be more information coming out about that if, in fact, this changes to those requirements.
Excuse, as of this time, there's no question in queue. Once participants over the phone, if you wish to ask a question, you may press star followed by the number 1. Please ensure your phone is unmuted and clearly record your name when prompted. To our question, you may press star 2. Thank you.
I'm seeing another question about when thinking about revisions to current programs. You mentioned something about looking at ER physicians' privileges from telemedicine. Could you please repeat that statement? And I can go back to that slide if that would be helpful.
Yeah, if you don't mind going back to that slide. So I believe the revision, it just clarifies if acute hospitals or primary stroke centers actually need telemedicine. So the question is that telemedicine isn't actually needed if the ED practitioners are privileged on diagnosis and treatment of stroke. So that's actually something that we at our stroke centers, that we pulled the privileges for the ED practitioners. So you go to your HR department and you pull a practitioner's file and you look at their privileges. What are they privileged to do at your hospital? And we added something specific about the diagnosis and treatment of stroke. I believe ours was more specific to aging. But for this particular standard, telemedicine, if an ED practitioner is privileged to diagnose and treat acute stroke, then telemedicine may not be needed at your hospital. So the first step would be to get with your HR department, fill those privileges, and see what your practitioners are actually privileged to do.
I'm looking a couple of questions. If you would be willing to share an electronic copy of the spreadsheet you used for current patient review.
I don't believe I actually have a copy of the concurrent review spreadsheet. I'll go back and look in my files and see if I have it, and if I do, I will be sure to share it again in Renee so that they distribute it. I'll also look to see if I have the gap analysis spreadsheet. If I do have that, just a disclaimer is that would have been from the standards in 2014. You would have to make sure that you through it and update any of those standards that may have changed. Look through my files and see if I have those resources, and if I do, I'll be sure to send them to Lynn and Renee.
Cool.
Just to let you know, still there's no queue on over the phone for the question. Once again, if you wish to ask a question, you may press star followed by the number 1. And to withdraw a question, you may press star 2. Thank you.
Again, I just have one question from what I hear from a lot of my stroke coordinators here is the issue of vital signs and neurochecks being done and documented to the clinical practice guidance that they're using. So I'm just curious, in your prior role as a stroke coordinator, if you have any helpful tips for if that's a challenge for you and how you overcame that at your organization.
Yeah, that's a really good question, and I think that's a challenge that probably every stroke coordinator experiences. So we did a different thing. So one would be obviously current review. If I didn't see that they were being documented at the frequency they were ordered, that's something that I communicated back to the staff as in close to real time as I could. We also created a stroke flow sheet, and in that flow sheet we included the vital signs and neurochecks that the nurses weren't having to flip through multiple different flow sheets for their documentation. And in the stroke flow sheet, we actually put the frequency for vital signs and neurochecks. So under the vital signs section, there was a note that said, if post-IVTA, sign should be 215 times whatever. So we had it spelled out in the actual flow sheet. And then something else that we did is we built a best practice alert. So when IVTPA was ordered and administered, there was a best practice alert that would pop up, being the nursing staff to document at that certain frequency. So there were a few different things that we did. You really just kind of have to get creative and see what will work for your staff. But that's an ongoing challenge, I know, across most hospitals.
Speakers at this time. Sorry?
That's okay, Steve.
Thank you. As of this time, there's still no question in queue. Proceed.
I think we're at the top of the hour here, but we wanted to thank everyone for submitting questions during registration and let you know that we do take those into account for planning. And if we didn't have a chance to answer the questions or anything in the Q&A box today, we will get back to you separately. So thank you for submitting those questions. I think Lynn and Laura, it looks like it's 12:01, so maybe if there's time for one more question, or we might need to close.
I just see one last question.
Okay.
Do most comprehensive centers have a dedicated data team? Not sure if that's something you know the answer to, Laura, or not.
I don't know. I know that we had a dedicated data abstractor, and that person definitely helped with the concurrent review process. I definitely cannot speak for the majority of comprehensive stroke centers, unfortunately.
A question to post to CSC Online Network where you could hear from some of the comprehensive stroke centers and your peers to get more of an idea of what other comprehensive stroke centers are doing, because I think that's varies across all of the different hospitals. So for the person that asked that question, if you're not familiar with how to post a question into CSC Online Network, please feel free to reach out to us and we'd be happy to show you how to do that. That we will conclude today's webinar. Thank you so much, Laura, for a wonderful presentation, and thank you to all of you for joining today's call.
That concludes today's conference. Thank you for participating. You may now disconnect.